This is the Physiology for Cardiology podcast. The overview is as follows. We'll begin with cardiomyocytes, then the cardiac muscle syncytium, then the cardiac action potential, the electrocardiogram and how it correlates with the cardiac cycle, the cardiac cycle overview in 3 steps, and then an in-depth analysis of the cardiac cycle. So let's start with the first topic, which is cardiomyocytes. The heart is composed of 3 major types of cardiac muscle. First, you have atrial muscle. Second, you have ventricular muscle. And then third, you have a specialized type of excitatory and conductive cardiac muscle. There's sometimes some confusion as to which ones are neuronal or muscle in origin. And when it comes to the SA node, the AV node, the bundle of His, and the Purkinje fibers, they're all cardiomyocytes. They're all muscle in origin. They're not neurons. The second topic is the cardiac muscle syncytium. Cardiac myocytes are typically uninucleated, having at most two nucleuses or 2 nuclei. They're connected in series or in parallel, meaning that they're branched. And in between cardiomyocytes, you have intercalated discs. At each intercalated disc, you have gap junctions that allow ions to diffuse. Hence, the intracellular fluid between cardiomyocytes are connected. And this allows action potentials to travel easily from one muscle cell to the next in the heart. Now, the heart is actually composed of 2 syncytiums. You have the atrial syncytium, which is composed of the atrial walls, and the ventricular syncytium, which is composed of the ventricular walls, and they're insulated. So atrial depolarizations can't just flow down straight into the ventricles because of this fibrous tissue. The way that the action potentials from the atria can get to the ventricles is that they have to go through the AV bundle. The next topic is the cardiac action potential. So you should first know a few concentration gradients. Sodium is always high on the outside, potassium is always high on the inside, and calcium is always high on the outside. The cardiac action potential begins at negative 90 millivolts. The way you should interpret or read that is that simply, like it's a very simplified version, but the intracellular side of the plasma membrane is more negative than the extracellular side. Hence, you have a negative membrane potential, negative 90 millivolts. Okay, so looking at the cardiac potential, how do we break it down? So first, you have the depolarization. This is mediated via voltage-gated sodium channels that open and permit sodium to rapidly flow into the cell. And because you have positive ions flowing in, it'll make the membrane potential more positive. And during this rapid depolarization, it will reach approximately 20 millivolts by the end. The second is the top side of this curve, which is the plateau. The cardiac action potential's plateau is mediated via voltage-gated calcium channels, and they permit calcium ions to continue entering the cell, whilst only a few potassium channels are open. And for that reason, you get this kind of plateau. And it's during this plateau that muscle tension also develops because you have calcium ions flowing in that can allow the actin and myosin fibers to start contracting. The third is the rapid repolarization. And during this step, the calcium channels close and your potassium permeability increases rapidly. And for that reason, potassium ions rapidly exit the cell. And because you have positive leaving, it makes the inside of the cell more negative. And so you repolarize back to negative 90 millivolts. So what you should keep in mind when it comes to cardiac action potentials in comparison to skeletal action potentials is that the sarcoplasmic reticulum, which is like a specialized ER, is less developed in cardiomyocytes. They store less calcium compared to skeletal muscle. For that reason, the cardiomyocytes are heavily dependent on the extracellular calcium concentration, because it's from there that cardiomyocytes get the calcium they need to contract. That's not the case for skeletal muscles. Most of the calcium ions for skeletal muscle contraction come from the sarcoplasmic reticulum. They're released from that into the cytoplasm where they can allow the actin and myosin filaments to contract. It is for this reason that if you take a heart and you place it in a calcium-free solution, it will quickly stop beating. And that's also why in hypercalcemic environments, the heart will also spasmodically contract. The next topic is the electrocardiogram and how it correlates with the cardiac cycle. So your P wave is a depolarization wave through the atria, and following it is atrial contraction. The QRS waves are ventricular depolarizations, and they initiate the contraction of the ventricles. The ventricular T wave, which comes after the QRS, is the repolarization of the ventricles. Okay, so you have P, that's atrial, you have QRS, that's ventricle depolarization, you have T at the end, that is ventricular repolarization. And where did the atrial repolarization go? Well, it gets masked by the QRS complex. The next topic is the cardiac cycle overview. So a human at rest, their heart rate is about 72 beats per minute. And each of those beats, or each of those cardiac cycles, occurs in 0.8 seconds, 0.8. We're going to break that down. So for the first half of the cardiac cycle, which is 0.4 seconds, the atria and the ventricles are both filling with blood. This is a state of atrial and ventricular diastole. During this phase, all the blood from the veins are flowing into the atria and then into the ventricles. Then for 0.1 seconds, the atria contract to kind of pump that residual atrial blood into the ventricles. And then the last 0.3 seconds of the second half is ventricular systole and atrial diastole, in which the ventricles contract and eject blood. All right, and now the last topic is the cardiac cycle. And we'll go through this in depth. For you to really understand this, you need to understand that the cardiac cycle pressure curve that you look at, it's focusing on your left ventricular pressure. And to understand this curve, because it can be quite overwhelming at first, you need to break it down into what's in systole, what's in diastole, what is the left ventricular volume looking like at this point in time, and which valves are opening and shutting, and which ones are open and which ones are closed. Okay, so let's begin at step 1. This is diastole, and more specifically atrial and ventricular diastole. It's going to look like a long flat line that's horizontal because the AV valves are open and blood is just flowing directly into the atria and then into the ventricles. There's no left ventricle pressure increase because you're just filling up the cup, but there is a steady increase in the left ventricle volume. 80% of your ventricular blood actually fills up this way. Okay, then moving on to the next step, step 2, we'll have atrial systole, if you remember from that cardiac cycle, where the atria contract to eject that residual atrial blood into the left ventricle. This is obviously initiated by your sinoatrial node, your SA nodes, P wave. This is how you get the last 20% of your ventricular blood volume. And that's where you see your first little bump in this left ventricle pressure curve. Keep in mind, the AV valves are still open and your semilunar valves, they're closed. Step 3. Now you have the QRS wave come in. And remember that initiates your ventricular contraction. So this will be a state of ventricular systole or contraction, but your atria will be in diastole, they'll be relaxing. As soon as the ventricles contract, the AV valves are going to shut to prevent backflow of blood into the atria. And this closing of the AV valves initiates the big hump in this pressure curve. Now this big hump, I'm going to break it down into the ascent, the rounded peak, and the descent. And note that this ascent is initiated by the AV valve shutting, which is the first heart sound called S1. Step 4 is the ascent part of this big hump. This is a period of isovolumic contraction, which is arguably, in my opinion, one of the most important concepts in cardiology, which is that water as a fluid does not compress. So once you close the valves, the AV valves and the semilunar valves, you have a closed compartment, the volume is fixed, but the pressure is going to increase because the cardiomyocytes are contracting. So for that reason, this is a period of isovolumic contraction, the ascent. Now, step 5 is, at some point during this isovolumic contraction, the left ventricle pressure is going to exceed that pressure. It's going to exceed the pressure within the aorta. And at that point, the aortic valve will open. And that will initiate the rounded peak of the big hump. The left ventricle is still contracting, and all this left ventricular blood is going to be ejected into the aorta, and that's why you'll see left ventricular volume decrease during this, the rounded peak. Step 6 is that the aorta will distend with all this new blood, and then it's going to snap back because of its elasticity, and the aortic valve is going to snap shut. This marks the last part of the big hump, which is the descent, and the period of isovolumic relaxation, which is the descent part of this big hump. Same thing, your semilunar valves and your AV valves are shut, the volume is fixed, but the left ventricular pressure will decrease. And it's the snapping of these AV valves that cause the S2 sound. Okay. Step 7 is that at some point during this period of isovolumic relaxation, the atria that are filling up with blood during this entire period, they're going to build up enough pressure, and it's going to exceed that of the left ventricle. And at that time, the AV valve will open up. And once the AV valve opens, that will conclude the left ventricle pressure curve's big hump. And you'll return to the initial step of just atrial and ventricular diastole, in which the left ventricle pressure isn't changing and its volume is just steadily increasing by passive filling. And that concludes your cardiac cycle. So let's just summarize it quickly. You have your long, horizontal, flat left ventricle pressure, whilst the atria and ventricles are in a state of relaxation, just filling up with blood. Then you'll have your atrial contraction, which fills up the last 20% of the left ventricular blood volume, and then your left ventricle systole will begin. It will contract, and when it contracts, the AV valve shut. That's your S1 sound. Then you have a period of isovolumic contraction, and at some point, the left ventricle pressure will exceed that of the aorta, and the semilunar valves will open. That's when you have your broad peak. The atrial blood will, and then the aorta will distend, and the blood will flow back, and that will cause the semilunar valves to snap shut, which is the S2 sound. And that will begin your descent, your period of isovolumic relaxation. And at some point during this relaxation, your atrium's pressure will exceed that of your left ventricle, and your AV valves will open, and then you'll return to a state of atrial and ventricular diastole relaxation, in which both compartments are filling up with blood passively. So that concludes your cardiac cycle, and we will continue with the rest of the cardiology concepts and topics in the next podcast.